the next question, as you said, norepinephrine is the first agent of choice. Now, of course, the next question would be which is the second agent? And when do I think of adding a second agent to the patient who is still in a shock and not responding to norepinephrine?
So the guidelines say the second agent is vasopressin, to keep that answer really simple, right? And surviving sepsis says start vasopressin somewhere between 0.25 to zero point 0.5 micrograms per kilo per minute as a general remark, right? Not a strict recommendation. I think to ask me philosophically, I would say the second agent is whatever your patient needs, okay? And I'll come to that later on. But say it's vasopressin. There is great heterogeneity in practice, and I'm sure it's the same way in India and the US. It's all over the place on when we want to start vasopressin. We have seen some very strong retrospective data. The early initiation of vasopressin is associated with a significant difference in mortality, right? Just association, no causation. So my personal belief is you have to start it early. By early, I mean somewhere around 0.1 micrograms per kilo per minute or 10 micrograms per minute of norepinephrine equivalents. The other way to think about it is when you're thinking of starting hydrocortisone on your patient, you should definitely be on vasopressin. That's my simple answer. The more complicated answer is, well, we still need to do those randomized trials that will compare early versus late initiation of vasopressin and whether it makes a difference in organ system failure and differences in outcomes. But the one reason I try to start sort of a more multimodal approach to vasopressors early is because I believe that if you wait for the norepinephrine to keep increasing and wait for failure of norepinephrine, then your patient is at a physiological disadvantage, right? Your patient is already in organ system failure. Your patient has lactic acidosis, metabolic acidosis, 2-system organ failure, 3-system organ failure. Then your second vasopressor is no magic, right? And then your third vasopressor, your patient's almost dead by that time. So there's no point waiting in a staged approach. People will also ask me, just to finish that point, why do we start vasopressin? We assume that everyone has a vasopressin deficient state in septic shock. In a perfect world, I should be able to test that, right? Now, this is not a perfect world we live in, so I don't think it's going to be possible to do that, at least today. But someday, I want to drive my vasopressors based on biomarkers. Yeah.
It's a perfect answer. I mean, amazingly, you answered to many questions. One is, of course, what is the second agent of choice? Then when do we start it? And also you added onto the information, when do we add cortisol, hydrocortisone as well? Because if we have achieved a certain dose of norepinephrine, that is the time we should be initiating the steroids as well as vasopressin. Just what I said. Thank you.